All right, good morning, everyone. We're going to get started. Today, I'm very excited to welcome two fantastic speakers who are going to share our second CROI report back, HIV treatment for the HIV provider. Dr. Annie Luetkemeyer is a professor of medicine in the Division of HIV, ID, and Global Medicine, and Dr. Gandhi is also a professor of medicine in our division and the associate division chief. Dr. Luetkemeyer and Dr. Gandhi are such phenomenal infectious disease clinicians and clinician educators, and we are so lucky to hear their thoughts and insights on the CROI 2025 treatment data. So we'll start off with Dr. Luetkemeyer. Thank you so much for being here.
All right, hopefully you guys can hear me okay. And thank you for having me. My disclosures are here. I think there's lots to say about the current environment, and I think this icon probably says it best. I think it's really emerged as, stand up for science, and science matters. And so I'm gonna let my iconography speak for it. For myself. So I'm going to cover a variety of things today in the treatment realm. I'm going to start out with things that are HIV adjacent, but very important for us. I'm going to talk about tecovirimat and citrovir for post-exposure prophylaxis, some hepatitis B vaccine strategies, and then get into some ART switch studies. And Dr. Gandhi is going to follow up and talk about more switch studies, and then briefly about HBV reactivation. And I'm going to really do my best to stay on time. Although I'm trying to, there we go. I got a timer right here so that Dr. Gandhi has plenty of time as well, and that we have time for questions. Okay, so we're going to warm up for a second, which is true. What I really should have asked is, how do you say it? Do you say tecovirimat or tecovirimat? I say tecovirimat because it is an E, but that's not the question here. So what is true regarding this drug, which we also call TPOXX? Okay, clinical benefit has only been demonstrated if you start it within 3 days. That would make sense because it's an antiviral. Benefit only in those with really severe disease. Hasn't shown clinical benefit in either clade 1 or clade 2 mpox, or it improves pain, but not time to symptom resolution. So well, here we go. People are voting. Boy, those words are really small there. I can't tell how many people are voting. It doesn't tell me. Okay, all right. Well, the answer is C, that unfortunately we've not seen benefit in clade 1 or clade 2. Oh, someone just took their one back, so they're paying attention. But I'm going to go over these data for you. So these come from the ACTG 5418 study, which had a great moniker, the STOMP study, to stomp out mpox, and it was a 2-to-1 randomized blinded placebo-controlled trial. And this was just, I think, a huge accomplishment that I just want to call out. It was conducted at a time when the CDC was already giving people compassionate use tecovirimat. They stood it up very quickly and enrolled a lot of people because we need clinical trials to tell us if drugs work. And remember that tecovirimat is an antiviral that we assumed would work based on the animal rule and some data in animal models of smallpox. And we were glad to have this as an option, but we do need clinical trials. And the goal here was to look for time to clinical resolution, which was all skin lesions, scabbed or epithelialized. And then they also looked at pain, viral load, PK, the whole thing. And I just want to say a big shout out to my team, as well as to all the folks in San Francisco who I think really responded incredibly to this really terrible outbreak that caused a lot of suffering for patients. And for our participants who are willing to be part of this study, we enrolled a lot of folks here, and we were very grateful for their time and volunteerism. Okay. All right, so what did we find with this? Well, I told you this already. The primary endpoint, the time to clinical resolution, you can't even tell the difference between the blue, which is placebo, and tecovirimat, which is the purple. And that's on the left-hand side. On the right-hand side, treatment change due to disease progression or severe pain, no difference. Adverse events and SAEs, those look the same, so pretty safe and well tolerated. And on the basis of these data, the study was stopped early by the DSMB on a futility analysis. So what can we learn from this, right? This did not, the way it was given, look like this was effective. Well, it was safe and well tolerated. There was no difference in pain. Viral load, I mean, that's what we're looking for here. Did it at least get the viral load down? Is there a reason to think this is working? Well, the histogram that I'm showing you shows maybe a signal at day 8, but that was not statistically significant. And in this similarly constructed PALM study, which was done in clade 1 mpox, boy, they did a beautiful study at a very challenging time and really did not see a difference in viral reduction. Subgroups, maybe there's a signal in certain subgroups, but not a big difference by age, race, ethnicity, symptom duration, number of lesions, prior vaccination. One piece that I think we need to learn more about is whether or not the dosing that we're giving to humans is the right dose. And there's some suggestion in going back to the animal data that we may have missed the boat, and that the PK that we have suggests that you'd need to give a lot more of the drug to get you into the realm that you would need to be. But I will say in these studies, people took the medications and we saw enough, med on board. We didn't see folks fail because they didn't take the medications. We just may not have aimed for the right dose. So what do we do now? Well, thankfully, we know that mpox in the United States, that the cases have become more sporadic, but this is still a problem globally, and mpox may come back. I think we still don't understand a lot of the epidemiology of why we've had resurgences. First and foremost, we should vaccinate people all over the world who are at risk of mpox, and that's really important. What would you do now if you had somebody with mpox that was severe? I think we can consider combination treatment with brincidofovir as with or without TPOXX, as there's some data for synergy with that combination. And then we clearly need more studies, so better antivirals. People are looking at monoclonal antibodies and then looking at brincidofovir itself. So more to come, but I think this is why we do clinical trials, and it's really important to have this. And we have 2 really well done studies in 2 different parts of the world, 2 different clades that showed us the same thing. So a little bit of a brighter spot. I'm going to shift to talk about ensitrelvir. Ensitrelvir is an oral protease inhibitor that is used to treat COVID. And this is a study looking at this medication as COVID PEP. So what they did is they looked at household contacts. And if you lived in a house with someone who had COVID, within 72 hours of them getting symptoms, and you had a rapid test that was negative, you could start COVID PEP for 5 days. And what they saw was a statistically significant reduction. Basically 3% of the household contacts who had PEP got COVID versus 9% who got symptomatic PCR confirmed COVID in the placebo group. So that was a 67% risk reduction. And importantly, other PEP studies have been done for COVID that haven't been successful with oral agents. There was some success with monoclonals, which is a good proof of concept. Benefit was seen with and without risk factors for severe COVID. It was generally pretty safe and well tolerated. I think the devil is often going to be in the details, and you have this medication with you, but you can really see that this might be a useful tool, particularly for high risk folks. I have people ask me all the time, boy, I'm getting on a plane, I'm older, I have immunocompromising conditions, I'm going to someone's graduate. What could I have with me if I get exposed to COVID? And it would be really nice to have tools for that. This medication is under IND review by the FDA. We don't know how that will turn out. I will say this medication is not approved for use for treatment of COVID in the United States, unfortunately, due to some work that my team and others have done did not show a statistically significant difference, but it is approved in other parts of the world. So more to come on that front, but I think it's a bright proof of concept. Okay, we're going to shift gears and talk about HBV vaccination. So which of these is true? High titer at the time of vaccine completion is associated with a durable antibody response, or is it not? In people with HIV, they're really only data for CpG adjuvanted vaccines, and I'm going to use the brand name Heplisav because it's so that we're all on the same page, but that's what that is. We only know how that works in prior non-responders. Is it that there's no difference in the serologic response if you use 2 versus 3 doses of Heplisav? In people without HIV, it's approved for just 2-dose use, but maybe we should give them 3. Or what about a mix and match strategy? Maybe the best thing to do is to give Engerix, which is the commonly used and approved Hep B vaccine, versus Heplisav, and mixing and matching may lead to a more robust response. Okay. So people are a little split between the high titer at the time of vaccine completion and that we only have data for vaccine non-responders. Well, A is true, and I'm going to show you those data, and I'm going to share with you data for vaccine naive folks as well as updated data for vaccine non-responders. Okay, so this is a little complicated. I try to use the presenters' slides, and then sometimes we'll add on top of them some of my clarifications here. So there were two groups here to the Beehive study. This was also an ACTG study. And in group A, they randomized people to get, these were non-responders. So people who'd been previously vaccinated, some of them many, many times, and it didn't stick. And we all know that this is a problem that we see both in people living with HIV, but in other populations, and some medical providers have struggled with this as well. So they said, we're going to take these non-responders and we're going to randomize them to one of three strategies. They'll get 2 doses of Heplisav, which is the standard approved way to do it at 0 and 1, 3 doses of Heplisav, so 0, 1, and then 6 months later, versus 3 doses of standard Hep B alum adjuvanted vaccine. And that's Engerix. And it was not double dose. It was the 20 milligrams, just so you know. Group B was just straightforward. They said, these are folks who've walked in the door. They've never been vaccinated before. They're living with HIV. Maybe we should just give them 3 doses of Heplisav. There's not a comparator arm, and that limits us in what we can say here, but still provides us with some much needed data. Okay, and they define seroprotection as above 10. Which is the standard definition, but they have a full range. And I think we really learned something about Hep B quantification there. So going back to this non-responder group and looking at 72 weeks, so they followed people all the way out. If people got 3 shots, there was a 97% protection. And if they got 2 shots, it waned down to 86% protection. You can see though, right before they got, this thing disappeared, right before they got vaccinated, the seroprotection was pretty similar, but there was some waning over time. When you compare this to sort of standard dose alum vaccination with 3, that's 57%. And I think we all would agree that that is not ideal. So what does this, I'm going to do conclusions in a second. And then the proportion who achieved protection at any time on study, but then were not protected at the end of study, was much lower in those who got 3 doses. So again, this was uncommon, but I think it does tell you that, you know, giving those 3 shots is probably your best strategy here for these difficult to vaccinate folks. They're not difficult to vaccinate, they're difficult to get a response. The vaccine naive group B, so what did this look like when we went out to 72 weeks? And they're showing in purple here the 3 shots. And remember, there's not a comparator, but so they overlaid here non-responders. Okay, so this isn't exactly what the study was designed to do, but they used all available data. And what you can see is that at weeks 72, 97% of people had a really robust response, but you also saw a pretty robust response in the standard the blue here is the non-responders with Heplisav in the other group. So both did very well. We don't have the overlay of how they would have done if they had just gotten Engerix, the alum vaccinated, the standard alum version, but a really strong response. I think the question this doesn't answer is, what if you just gave them 2? And many people probably would have been fine with just 2, and that's what we standardly vaccinate people with when you give them Heplisav. When you get into a little bit more what the level of the titers are here, and it is a little bit small to see, but any blue is protective and darker blue means that the titer is higher and higher. So the darkest blue is above 1,000. What you can see in the non-responders, and the first bar is that primary at week 24 and end of study at then 72 on the right. You can see that the level of response is higher if you give people 2 doses, both at the right after vaccination and at 72 weeks. And you see that in the vaccine, you know, naive group as well. So the suggestion being that more vaccines that you're given leads to a more durable response, at least at 3 years out. So what is my take home here? I think for non-responders, I'm pretty convinced that trying to get that 3rd shot in is probably your best bet. It's hard to remember because it's month 6, but at least get 0 and 1 in. And if you can get month 6 in, I think you're going to be in better shape for a durable response. Treatment naive, you know, I would probably, whether you need 3 doses or not, to me, I don't think these data can answer that. And do you even need to start with Heplisav for everyone? Well, we know that folks living with HIV may have a lower response rate. Many clinics like our own have just moved to giving everybody Heplisav, certainly a reasonable approach for people who are immunocompromised, older, that you're concerned about. And if you're really worried, I would give them the 3rd shot. But if you can get 2 shots of Heplisav in, I think you're doing a pretty good job. Okay. I'm going to shift gears and then come back to Hep B at the end, I promise. There's a little bit more Hep B for you. So I'm going to talk about two different switch studies. The first one is a study that was run by GSK, and it's called the EMBRACE study. And for disclosure, I was one of the study investigators, and we enrolled participants here. So it was great to have on the ground experience with this study. And they looked at the strategy of, well, can we switch people from, all oral? We know all the excitement about giving people injectables. They switched them once they were suppressed and doing well on their ART to monthly intramuscular CAB. They didn't give it every 2 months, which I know we often are doing now, but when the study was designed, this was every month. And then they gave it in combination with the BNAB. I have this up in my office for those of you who've been there because I can't keep track of the name of all the BNABs. So I thought this might be helpful for others. And just remember that there's multiple sites on the envelope that are conserved regions that this really exciting group of medications, the BNABs, target. So this particular BNAB targets the CD4 supersite, and it's called NSL6. There are other BNABs that we may be familiar with that also target that similar region, VRC07, and then there's a 3BNC 1117LS. And you might have heard some of these during CROI, but it's just helpful for me because I can't keep all these numbers straight in my mind. Dr. Gandhi is going to talk about a 101074 that's a V3 supersite as well. So to orient you to the envelope and what we're targeting here. So individuals were given CAB plus the N6LS, either subcutaneously or IV every 4 months, right? So they're getting CAB every month and then every 4 months. And the goal is to get to longer and longer, stretches. But this was more of a proof of concept to see how they could get to that versus continued oral ART. And it was a 2 to 2 to 1 open label randomization. And they excluded people who had active hepatitis B because this is not a Hep B active regimen. So what did they find? This is the typical histogram for the FDA snapshot analysis. In the dark blue, this is the IV. In the light blue, this is subcutaneous, and this is oral standard of care. And what you can see in the snapshot is that the virologic response rates were generally fairly equivalent. There were 4 of 5 participants who had an HIV RNA of greater than 50 that met confirmed virologic failure. So in the IV arm, there were 2 folks. Neither of them failed with INSTI-RAMs, but both of them failed with resistance to the BNAB, which is notable. And in the sub-Q arm, there were 2 individuals. 1 participant failed with the INSTI resistance mutation, and neither failed with antibody resistance mutations. All of the folks who had confirmed virologic failure resuppressed with standard of care ART. Which I think is helpful to know. They did not use an integrase, I don't believe, for the person who had failed with an integrase resistant mutation. They did not see any adverse events leading to withdrawal. There were no serious AEs related to CAB or N6LS, but they did see more injection site reactions with the sub-Q version. They were really trying to see if they could get away with not giving people an IV, but I think that this was not well tolerated. So they are moving forward with an IV, the IV NSL6 given every 6 months, and they're trying to extend the duration of long-acting CAB and to see how far out that can go, potentially up to 6 months for evaluation of part 2 in EMBRACE. And what I think that the sub-Q piece here, I mean, these numbers are small, but I don't love the 88%, but the 96 and 96, I think showed fairly virologically equivalent there for the IV versus the oral standard of care. More to come on that front. Okay, the other 2 switch studies that I'm going to combine and talk about together, and I was thinking as I did this, what icon do I think about for Switch? And I was delighted, remember when this came out, the Nintendo Switch, and then it turned out, spoiler alert, it's the same color as the histogram. So I got really excited. You got to take your wins where you can get them. So these are switch studies that combine doravirine and islatravir. So just a reminder what these are. Doravirine is an already approved oral NNRTI. It's given at 100 milligrams daily, and it does have activity against some NNRTI resistance mutations, including K103N, which we've seen with prior NNRTI exposure. Islatravir is an investigational NRTTI, so transcriptase translocation inhibitor. It does have in vitro activity against M184V, which is helpful to know. And as you all are probably familiar with, development at the 0.75 milligrams was stopped due to decreased lymphocytes and CD4 cell counts when dosed at that level. This evaluation looked at 3 times lower dosing at 0.25, and they're also exploring weekly dosing in future studies. So 2 different studies. The one on the left was a blinded study and took people who were already on, both were suppressed. Neither of these are treatment naive studies. So switching from BIC, TAF FTC to doravirine islatravir, or open label on the right-hand side on whatever they were on, virologically suppressed, and then either stayed on that oral ART or switched over to doravirine islatravir. And again, what you can see is that the virologic suppression was considered non-inferior based on their pre-specified evaluation here. And I think they got reasonable suppression rates here. And blue is doravirine islatravir, just to remind you. So 91 versus 94. And then this was slightly inverted at 95 versus 91.9 for standard of care. Interesting, yeah, standard of care. Interesting that some folks lost their virologic suppression in the standard of care ART, which is a little unusual. But let's dig into then the confirmed virologic failures. So in the blinded study, this BIC switch study, 2 doravirine islatravir with confirmed virologic failures, they had no resistance. In the open label study, there were 5 doravirine islatravir folks who had a viral load of greater than 50. 2 of these stopped at week 4. They never suppressed. They had a lot of resistance mutations, and it turned out that they were unfortunately shouldn't have been enrolled in the study. They found evidence that they had prior resistance mutations that were exclusionary. So this is unfortunate. It does happen, but they were ineligible participants. 3 individuals had confirmed viral failure. 2 had genotype results. 1 failed to run, and 1 had no doravirine islatravir resistance. And each of them had one NRTI resistance mutation, and 1 had 215 T/I. So no emergent resistance mutations, and 1 of them had this at proviral screening. They both suppressed and went back on integrase related ART. A lot of interesting questions, though, about switching and what some of the profile would be when you change people. So first of all, they didn't see the T cell or lymphocyte decreases. So that is good news, because that obviously was a big concern at the higher dose. Weight change, what happened to these folks? A lot more to say about this, but those who were in the open label who stopped weight suppressive ART, which we typically think of as efavirenz and tenofovir, they did see weight gain, and that makes sense. However, those who switched to either doravirine islatravir or stayed on BIC TAF FTC, there really was no difference in their weight change. It was very small, by 0.3 kilograms. It was not statistically significant. And they'd been on ART for about 3.5 years at that point in time. Interestingly, a similar combination of doravirine islatravir at the higher dose was recently published, and this also showed that it was weight neutral. And this is a real question. Gosh, we know most of the weight gain or can happen right up front. Would it make a difference if you chose a different regimen? I thought it was notable the weight gain that they did see in people, 3 kilograms in both arms, and this is at week 48, but there was no difference. I'll just point out that there is an ACTG study that is coming out looking at switching people who've had a lot of weight gain onto a doravirine-based regimen, not with islatravir, and those results are anticipated. So I think what we continue to learn is that once people are suppressed on their ART, changes in their ART beyond efavirenz and TDF have not often led to substantial changes in weight, and we really need to have better tools to understand how to manage unhealthy weight gain. Hep B, and I told you I would come back to Hep B and land the plane here with this and then another abstract. Want to point out that these are Hep B sparing regimens, the one that I presented before, as well as doravirine islatravir. And people could not have had active hepatitis B, but they certainly could have had Hep B in the past to qualify. So there were 3 cases of low-level Hep B viremia. They were all core antibody. They'd had previous infection with hepatitis B. 2 were surface antibody positive, and 1 was surface antibody negative. These were not clinically significant. They didn't have transaminases that went up. They resolved when they followed them. But it's a good reminder that core antibody means hepatitis B is in your body. And we need to be thoughtful about that. And even people who are surface antibody can reactivate, although it is rare. maybe more distressingly, 2 acute Hep B infections occurred, and these are in people who had no, serologic protection at baseline. So we need to vaccinate people. We have great tools. I just shared with you that we now have, options for 0 and 1 month that people respond very well to. So just a really important reminder as we move into territories of using tenofovir and Hep B active sparing regimens, and we're going to have more and more of those, that we need to have Hep B on our radar to keep our patients safe. So what's really the scope of this? Is this a big problem, a little problem? What's a big problem when it happens to your patients? So we should vaccinate them, and we need to monitor people and be thoughtful about this. This was kind of a nice summary. They called it a scoping review of 7 studies and 8 case reports of reactivation of people on tenofovir sparing regimens. And I'll say 2 things. When you look at these data in general, I would always ask yourself, are we talking about tenofovir sparing or fully Hep B sparing? Because we know that FTC and 3TC also have some Hep B effect. And so you want to know if you are in a completely Hep B free regimen or if there's a little bit of suppression on board. So to be critical about that when you look at this. And they did a nice job here and by breaking that down. And what they found is that reactivations occurred in about 1.1%. So not a huge number of people switching to completely Hep B sparing regimens, but that the range really depended on what the study you were looking at and the population. So anywhere up to 10%. This tends to occur early, although not always, but you really, they were reporting in the first year. But I will say many of these studies haven't followed people over tons of time. And I think we know that reactivation can be in conjunction with illness, with immunosuppression, with aging. So you are at risk at various points in time, but we do know changing ART may be a time of particular vulnerability. We also know that all risk is not the same, right? If folks have a core antibody, they are at risk, but those with surface antibody have lower risk because they have some protection. The people we're worried about have no surface antibody. And certainly if they have surface antigen, I wouldn't even put them in this category. They have active hepatitis B. And if they have active hepatitis B, it doesn't mean you can't switch them to something life-saving like Cabril if you need to do that, but you need to have the discussion with them about, yes, and how do we treat your hepatitis B? You need to monitor folks carefully. Okay, so how will these potpourri of studies change my practice? Well, for Mpox, I'm not using tecovirimat. Luckily, we're not seeing a lot of Mpox in the United States, but we know that we probably will see resurgences down the road. I hope not. If I had a severe case, I would consider dual therapy. You can get brincidofovir as a single-use IND from the CDC. We've done it. It's not easy, but it can be done. But we clearly need better agents, and I hope that they will really keep the pressure up for this because this is a real issue around the world. And this is why we do clinical trials, because things that seem like a really good idea, we do need to test them and understand how well they work in a randomized control fashion. Hep B vaccination, non-responders, I think very reasonable to use CpG adjuvanted vaccine with a goal of 3 vaccines if you can get them in. Vaccine naive, hey, I think it's great to use CpG adjuvanted if it's available to you, particularly if risk factors for poor response. I think a goal of 3 is reasonable, particularly if they have risk factors, but 2 is probably fine for most comers. Do check your response, right? We know some people don't respond, and I think the guidelines tell us that we should check to see if people respond. I think we often forget to do that, and I should have put that bullet in here. Tenofovir sparing ART and then fully Hep B sparing ART. In general, I just think we got to keep Hep B serologies on the radar. Surface antibody, core antibody, and surface antigen, vaccinate them if they're surface antibody negative. And as I said, continue Hep B treatment if surface antigen, either as part of their ART or as an adjunct to their injectable ART. If they're surface antigen negative, remember this and keep this on the radar if LFTs go up. I think a really exciting time for new antiretroviral strategies that are coming that may be weekly, monthly, every 6 months, and that may be better fits for people and reduce associated comorbidities. So an exciting time for this, as well as potentially a PEP option for COVID. So I'm going to stop there and turn it over to Dr. Gandhi. Oh, and then I just want to thank everyone who showed up and continues to show up for our sciences.
Thank you, Dr. Luetkemeyer. We're going to do a few questions and then turn to Dr. Gandhi. One question in the chat was any issues with insurers covering the third vaccine for non-responders or those with risk factors for poor response? Do you know any, have you had any issues with that?
No, but I think we are in a bit of a unique, I mean, the way we provide it here may not be the same way for reimbursement. I see Dr. Hare, who's in a managed care organization, and I wonder, Brad, you have trouble getting HEPLISAV covered?
Yeah.
Or what
Kaiser is also a unique situation, and no, we don't in our situation, but I can imagine in some fee-for-service or outside insurers may have some issue.
And if you couldn't, if you had a challenge, I think that the goal check serology and then see where you are, and then you can make the case, hey, it didn't take.
Great. We'll take a few more questions from the audience.
Does HPV immunity wane after HIV seroconversion? Is there any data on that?
So we know that HPV immunity can wane, and that's why we use the 10 as the goal here. We know that immune compromising conditions can affect that. The data that I've seen for HIV is more that they don't respond well to vaccination. I don't know that I've seen good data on waning rates being higher in people with HIV, but I'd have to go back and look, and others may know about that. But I would certainly think, as we know, HIV is very heterogeneous, and folks who've had severe immunocompromise, it would stand to reason that they might have a poorer response. Yeah. And just a reminder, because this comes up all the time, people say, well, am I really supposed to vaccinate someone if they're core antibody positive? Like, in HIV, the consensus is yes, you should vaccinate those folks, but it's an area that's a little murky.
Great. Other questions? All right, we'll move over to Dr. Gandhi. Thank you, Dr. Luetkemeyer.
Okay, so this is the continuation of the treatment sessions from CROI. Next week will be prevention. And I would ask you, did the data from CROI 2025 change your clinical practice yet? And the answer would be yes, no, or it made me want to wait for some of these new drugs or drug combinations that will come out. So please vote. So already 40% of people in this audience and online have already changed their practice from the data at CROI. And I think that's really interesting. It's about a third of each. I think I'm really interested in the new drugs. And it made me think about resistance a lot. So we're going to talk about INSTI resistance. So what we will cover here is the CARES 96-week data, the len-tab-zab study, yearly lenacapavir, VH184 and VH499. I feel better about the latter after really looking at some dosing. And then I want to do bottom lines on what I think happened at INSTI resistance. So in terms of the CARES trial, we all remember what this is. So this was a study performed in Uganda, Kenya, South Africa, that looked last year. We had the 48-week data, and that was published in May 2024 in Lancet ID. And this was at this CROI was the 96-week data of this study. This was a randomized trial, keeping people on whatever oral ART they are, because it was in these 3 countries. 92% were on TLD. 73% had NNRTI experience. That's terribly important. And then they got randomized to long-acting versus staying on oral therapy. And the baseline characteristics, I want to note 3 things. 1, 20% had a BMI of greater than 30 kilograms per meter squared. Second is that 74% had prior exposure to NNRTIs. And third, that 92% are now on dolutegravir. So you all remember, and this I really needed to try to understand, and I called Bob Schaefer and I called Peter Hunt, and I really tried to understand this second part. So what was this thing about cDNA? So remember that what happened at 48 weeks last year, and in the May 2024 Lancet ID, they had presented the cDNA, the archived DNA resistance at 48 weeks. And remember thinking, wow, that's a lot of archived rilpivirine resistance, 14%, a lot of archived cabotegravir resistance, 16%. So what they did here was exclude APOPEC related mutations. To put that simply, like super simply, it's essentially if these particular mutations are not transcriptionally active, then let's just exclude those mutations and go down to what was the real rate of mutations in the archived genotype in the cDNA, and it was much lower. Rilpivirine intermediate resistance was 3%, and cabotegravir intermediate resistance or high level was 2%. So that I think is so interesting, because I think that means you can have as much experience as you want, but if you haven't virologically failed, you have very low level resistance to rilpivirine. And I think it explains the results that we're going to show next, which are that there were really high rates of virologic suppression, even at 96 weeks, the same as 48 weeks, 97% retention of virologic suppression. So I think if you've had experience in the past and you didn't obviously fail, I almost think you have to just stop worrying about that, that you have significant, that you're going to fail in the future, meaning the whatever little cDNA resistance there is, it's not transcriptionally active. It's not coming out. These are latent proviruses. So 81% also got all injections, 97% on time. And treatment satisfaction was good. I mean, it was a very simple question. Do you prefer long-acting ART? And 99% of people did. So in a year or 2 years, they're going to be kicked off the study, but because there's not accessibility even for these trial participants. And that is really also the big message, that rilpivirine, for complicated reasons and has to do with drug company, has not been made available or accessible in low and middle income countries. So the next question is, of the 4 failures, because there were 4 failures by 96 weeks, what percentage of them had a high BMI? Because 20% had a high BMI. Was it none of them, 25%, 50, 75, or every single one had a high BMI? Those failures were because of supposedly low levels. So please vote. So no one said all 4 had a high BMI, and majority of you said none, which is actually true. So, I mean, that was really asked a lot, that, what's the BMI of those, well, at least above 30. What was the BMI of those who failed? There are 4 failures. The BMIs are highlighted here at the bottom. So 22 to 20, or I don't know, 20 to 26. And 1 couldn't be genotyped, and the other 3 failures had resistance that developed in both the integrase and the RT gene. So 138K and Q148 and N155. So just like in all the failures across the board, usually you get INSTI resistance and an RTI resistance, or both, and that's what happened in these 3 failures. So when you fail hard, but this was 512 participants, and half of them were on a long-acting Cabril. So this is a pretty low rate out of 260. So those are the failures. And then my next question is, how does Ward 86 decide which mutations are clinically significant to exclude when using Cabril? So we only use HIV RNA genotyping. I will tell you that the data that came out from 96 weeks here and the ApoPec being taken away made me even more comfortable with that decision to use only the HIV RNA genotype. We only exclude mutations seen on breakthroughs with virologic failure in the treatment trials or in the HIV seroconversions in HPTN 083. The trials that we're looking at is FLAIR, Atlas, Atlas 2M. Those are done. CARES, now we just got 3 more data points. SOLAR, that was comparing Cabril against Big TAF FTC. JAB, study and adherence challenged populations in Australia. SPLASH cohort, our own, ECHO Thrive, and any other study, including the Emory data, for example, on Cabril. So Anne Fenton in the audience is doing a huge detailed analysis of every single failure. She's going to add in these 3 from CARES, and she showed me a spreadsheet last night. It's very impressive, and it's coming down to a handful in CAB actually. It's really quite not as many in CAB as you would think, and we're not going to exclude a mutation that we haven't seen in these failures because we're getting so much more data now on the failures. So Anne will be publishing something soon, and she will also be helping us update our protocol. So my next question is, do you think BNABs will ever be used for HIV treatment, not cure routinely? And I didn't even know what Annie said, like when she showed that like 3-dimensional, I didn't even know what the one I'm supposed to talk about, TAB-ZAB, interacted, so where it was. So thank you for showing me on the molecule. So yes, no, likely only for drug-resistant virus, or I don't really see pharmaceutical companies signing on to make. So yes, no, for drug-resistant virus, where you can't use something else, or I mean, it will rely on marketing and pharmaceutical companies making them. So majority are saying it's probably going to be reserved for something where you have MDR HIV and then the envelope still has susceptibility to these broadly neutralizing antibodies. So I think that's actually what's going to happen personally, but I don't know. So what is Annie already talked about Embrace, which is N6LS. So we're going to talk about the Len-TAB ZAB study. So everyone was virologically suppressed, and this is the 26-week data of everyone being virologically suppressed and randomized, small study, right? Only 53 in those who got the injectables, and 27 stayed on their oral baseline regimen versus everyone got one dose of the 927 milligram of lenacapavir, one IV push of TAB, and one IV push of ZAP. So, and this is going out to 26 weeks. This will go longer, but this is the 26-week data, and it'll go out to 52 weeks. So what do the 26-week data show us? Well, again, only 53 people in this arm, but of those 53 people, essentially one participant failed. So one failed. And this came out in the question answer, but that particular person who failed had super low lenacapavir concentrations. And everyone kept saying, do they have a high BMI, which someone asked, like 2 people asked, but there's not a relationship that I know of BMI and lenacapavir pharmacokinetics, and they didn't. And I don't know why they had such low levels, and no one does. And you know, lenacapavir, I think of is more capricious when it comes to drug-drug interactions because it has both CYP3A4 and UGT1 metabolism. And beyond that, so lots of drug-drug interactions. And then maybe it's the pharmacogenetics of this person, but this person had a low lenacapavir level. So they were on just the 2 BNABs and they lost their ZAB susceptibility by the time we got to 26 weeks. So, you know, you have to have levels that are okay. So I think you could say that it could be used, like if we had a very MDR HIV person, we'd first have to check ZAB and TAB susceptibility. We'd have to be able to get the drug, and then we'd have to confirm that their LEN levels were upholding them, because 2 BNABs are not going to do it. So that's what I learned from this study. Okay, and then what about the once-a-year lenacapavir? Now, for one thing, I'm very interested in pharmaceutical companies when they make harder to use products and then suddenly like easier to use products come out from the same company. But I just think IM is easier than sub-Q in general. Why? Because we all know the issues with sub-Q lenacapavir. It's oily, it's bright yellow for some reason, it leaks out sometimes, it hurts, and it causes nodules. No matter what, it causes nodules. That's the depot formulation under the skin. So IM seems to be really tolerated for CAB and RIL. So I do think an IM formulation, forget about the once a year, though I'm going to talk about that, even IM once every 6 months, reduce the dose, would be nice to give with cabotegravir if we ever do that. So IM over sub-Q, I've in our experience at Ward 86, there's an interest in intramuscular. So importantly, these 2 formulations, I'm going to give you the data from the Lancet paper that came out the same day, because the Lancet paper had more data in it. This is essentially looking at 2 lenacapavir intramuscular formulations. One was in 5% ETOH and one was in 10% ETOH. And it was just a PK study to compare IM lenacapavir with subcutaneous lenacapavir concentrations in 20 people. So intensive PK and then safety evaluations. So in terms of the PK, the pink here is the subcutaneous lenacapavir formulation, and these are the plasma concentration time profiles over. Sorry, this is the intensive PK. So you can see that either the 5% or the 10% alcohol formulation, the levels were higher with the intramuscular formulations, and in fact, probably maybe too high. Like, I don't know if they, they're probably going to bring down the dose because they were really high. And importantly, in terms of the side effects, no nodules, not surprising, right? You don't get nodules with IM formulations. So that was really good. And then here is the actual comparison of the AUC. So you can see they're just higher than the subcutaneous formulation. So I don't know if, I think they can bring down the dose and do some more PK studies with these, but it will be nice eventually not to have the sub-Q formulation of this drug. Okay, and then what about pipeline? So I, after really looking into it, I was worried about 499, and then I got less worried after I looked into it. So because I'll tell you why. So these are two pipeline formulations. One is VH184, starts with a V, so it's made by a drug company that starts with a V. And then the other one is VH499. So these are a third generation integrase inhibitor and a capsid inhibitor, respectively. And remember how what you do at the very beginning, still not sure I love this, but what they do at the very beginning is give this as monotherapy to people living with HIV who have a viral load of greater than 3,000 copies per mil in this case. They all had to have CD4 counts of over 200. Give it as monotherapy and then see what happens to the dropping of the viral load. And you would expect an INSTI to drop like an INSTI, like a really rapid drop. So we'll see with VH184 and then the capsid inhibitor. Why are these two products being studied? Because the way that they look, it looks like they can be given as injectables, as long acting. I don't know what the intervals that's going to be, and it's not oral, it's long acting, it's injectable long acting. So this was only 20 people essentially in each study, this phase 2A. And there were 3 different doses of VH184 given and 3 different doses of VH499. So let's look at that. We'll think later about the 25 milligrams of VH499. And they were given on, over a week, like a couple times a week, 2 or 3 times a week. And then what happened to the viral loads is the question. Remember this data from IAS 2024. VH184 is that one compound that, at least in vitro, seems to work against dolutegravir-associated mutations. We're going to get into resistance in the next part of this talk, and it would be really helpful, I think, if we can have an oral INSTI or a long-acting INSTI that works against dolutegravir mutations, especially if what's happening in the world and funding cuts lead to an increased rate of INSTI resistance in the planet. So this is nice. This is going to retain, looks like this could work against those drug resistance mutations. So going back to the data then that was shown at CROI 2025, of the VH184, it drops viral load like an INSTI, so really rapid drop with all 3 doses of the VH184. So you always, they'll decide which one they choose, right? This is orally given 3 times a week. That's not what's going to be used. And then if you look at clinicaltrials.gov, there is ongoing phase 1 studies for each of these agents as injectables. It's just given once and then looking at the PK. So again, I don't know what the duration of, what the how many X weeks is going to be given over. I don't know what the PK will determine that. But the VH184 is sub-Q. I don't like sub-Q as much as I am. And then VH499, it looks like there's a sub-Q and an IM formulation. Okay, then if you looked at VH499, also dropped the viral load at all 3 doses. But importantly, there was one participant who got a capsid inhibitor mutation in the GAG gene. in the 25 milligram dose. So maybe if you give it at higher doses, you're not going to get that, because what you could take as a bottom line is there were only 20 people, 1 out of 20 got a capsid inhibitor mutation. This has a very low genetic barrier to resistance, these capsid inhibitors. But I don't know, it was a lower dose, like you can get that with lenacapavir if you let it leak out into the gauze. So maybe I'm sure they'll go for the higher dose, and maybe it's not. I still cannot tell you that I think I know the genetic barrier to resistance to lenacapavir. I am like really struggling with that question. Okay, so that is kind of the new drugs. But then I ask you, and this actually wasn't presented at CROI, so you're just gonna have to guess. There is a big cadre studies that are being conducted by the CDC before a lot of the decimation of CDC staff on April 1st. But my question is, what is the strongest predictor, at least in the cadre study, of dolutegravir resistance on TLD in this large multi-country resistance study? And no answer is wrong, but there's just the one that had a very high odds ratio. Is it prior experience on NNRTI regimens? Is it NRTI mutations? Is it NNRTI mutations? Is it being male? Or the longer time you're on TLD, the higher risk you have of resistance? Okay, so NNRTI mutations is an interesting one as the highest number. And I think that's speaking to the fact that you really mean NRTI mutations, which is B. So like, yeah, the same thing. I mean, if you've had experience with past regimens and you've actually developed resistance, then you're putting TLD on top of NRTI resistance. That is, at least in the cadre studies, the highest predictor odds ratio of developing resistance. Doesn't mean that all of these aren't predictors of resistance. Actually, they all are. And so I really want to thank Joe Watabe for making this figure for me. I think that these are the developing, these are the predictors of resistance on dolutegravir, underlying NRTI resistance, treatment experience, putting TLD on top of viremia versus switching over when you're already virologically suppressed on efavirenz TDF FTC. Of course, prior experience with a first generation INSTI, being a child versus an adult, yes, higher rates of resistance. And dolutegravir dual or monotherapy makes sense. And then we're going to talk about exposure. We're going to talk about drug levels. So we all know that the resistance report came out coinciding with the last CROI meeting in 2024. This was the last WHO drug resistance report. And there was already this kind of low level, but resistance, it had been now, 6 years since the rollout of TLD. There's resistance in the world. So let's talk about kind of all the data from CROI on INSTI resistance. Want to give credit to Matt Spinelli for several of these slides, including this one. So in the symposium that happened on Wednesday, which was really full, and this is the last session, putting it at the end was a good idea because it's a really exciting session. Overall, there were a series of talks that were good. And what are the kind of bottom lines? So transmitted dolutegravir resistance is rare. So that's really different than NNRTI, right? Like NNRTI transmission of resistance happens, which means even this many years after efavirenz was first line, we're still seeing a lot of NNRTI resistance because there's transmission. This is actually, I don't know why. It's harder to pass on INSTI resistance. In fact, we'd have higher rates of INSTI resistance if it was transmitted. So, but there was a modeling study. South Africa is a really important country in which to conduct HIV research because it has the highest HIV burden. And there was very important studies that in those who are failing by 2040, that we're going to see higher rates in those who are failing of INSTI resistance. So with the current approach. And that current approach didn't even take into account, the austerity measures that are happening right now. So I think it's going to rise. And I really want to give credit to Max McClure. We wrote this paper in Lancet ID, but really tried to explain that I think there's going to be increased resistance to combination therapy for either TB or HIV in the setting of strangling ART access worldwide because people are taking already drugs every third day, every fourth day, trying to make their drugs last longer. And so I do think we're going to see increased resistance unless there was a PEPFAR hearing yesterday, unless the right thing happens. So what other kind of major messages from this session? Well, tenofovir is the best backbone to be used. So don't use AZT. Like actually someone said in the session, AZT should just be like totally gone. And that was based on an audio study. Resistance testing is expensive, but so is switch. And this was really an interesting mathematical model that whether you just blind switch to PIs or you do resistance testing and then switch, it was kind of the same estimates of cost. So are there other ways to figure out who needs resistance testing before you get to that failure? And we'll talk about 2 abstracts from CROI that address that later. HIV viral load is $22. HIV drug resistance test is more. And drug levels for HIV drugs are not as expensive as a resistance test, but I don't think you need a drug level. I think you could do a cheaper test, which is the urine tenofovir test. So, and then the other thing that was talked about by Sekou, who's who actually thinks about, he's a pharmacologist, about the how variable cabotegravir and rilpivirine concentrations are in settings like the Swiss cohort study or the French ANRS study that have looked at cab-ril concentrations lower than thought. I think technique is terribly important. If Jake's doing all the cab-ril injections, we're great. And also Des, and thank you, and others in this audience. But maybe we're going to need, this is going to be the one place where TDM we have to think about. So what about triaging HIV drug resistance based on a drug level? We had, this is just a correspondence piece in Lancet HIV last year about using the urine test for this. But the entire point is if you have a high viral load and high adherence, that's a scary, that's a situation where you could have resistance because you're taking your drug and you have a high viral load. It's that green box there at the bottom. So what are 2 studies at CROI that looked at this? There were 2 studies that looked at the relationship between dolutegravir levels and drug resistance. So these were done by Kim Stegan and Koester, and essentially putting it all together, looking at different people, samples where drug resistance had been detected on TLD. The strong predictor of being resistant was having a dolutegravir plasma level that was positive, detectable. Because again, if you're not taking your drug, there's no selective drug pressure to evolve resistance. Really strong negative predictive value in both studies. So those were really interesting studies. And then I'm going to end because I do want time with questions, and I really can't explain all of this. And I'm not even sure I understand this, but I will say that there's been this intriguing interest. There's been this interest in when you have resistance outside of the GAG gene, outside of the INSTI gene, that resistance mutations in the nucleocapsid conferring reduced susceptibility to dolutegravir. So usually we look at the actual gene that codes for the enzyme that the drug works against. So we look at INSTI mutations, RT mutations, PR mutations. But several groups have reported that there are mutations outside the integrase gene that confer resistance to INSTIs. INSTIs are the only drug class where this happens. And so this was a study performed by Urvi Parikh et al. In the 5381 study. This was a observational study in the really important network of the ACTG that looked at rollout of TLD in PEPFAR-supported countries. And mutations selected by TLD were identified by comparing pre-TLD and TLD virologic failure in plasma samples. And there was very few INSTI mutations because most people, going back to our dolutegravir drug levels, actually who failed were not taking the drug as looked at by tenofovir diphosphate concentrations in dried blood spots. But there were some mutations, some people who failed, where they actually didn't have drug resistance mutations in the INSTI gene. Their drug resistance mutations were in the nucleic capsid. And there is a paper that tries to explain that. It seems like selected envelope mutations confer resistance by increasing infection capacity of the virus. So not really sure why. I doubt we're going to look at nucleic capsid sequencing right now for INSTI mutations for INSTI failures in a widespread manner. But I think it's a really important question for the future that should be funded by HIV research initiatives at the NIH. So I'm going to end there. I think my bottom line, I'm sorry, I really meant to do a bottom line slide. So I'm just going to tell you what I wrote down right now for my bottom lines. Cabotegravir and rilpivirine is good, but we need access. And I think having experience to NNRTIs in the past is okay. BNABs, they're not available, but I think if they end up being available before drug resistance virus, new agents, these two are ones to watch. An INSTI that works against dolutegravir resistance, that's great. And then VH499 will be interesting. And then last thing is resistance is happening. It could increase. Really important to figure out that you don't want, ever high levels of resistance. So think about the consequences of your actions when you do crazy things. Okay, thank you.
Thank you so much, Dr. Gandhi. We have time for maybe one or two questions from the audience. Anybody? Oh, okay. Well, our speakers are up at the front if you have questions, and thank you to you both